All right, well, welcome everybody to our May learning session for the Adolescent and Young Adult Behavioral Health CoIIN. I'm Eliana from AmChip, and we will go ahead and get started. So again, it's May, whether you are unmasking, getting vaccinated, dealing with your seasonal allergies per, return to normal, or if you're on the East Coast and dealing with the cicada season that's come only every 17 years, we want to say welcome. I know it's a busy month. We have graduations, we have commencement ceremonies, and so we are very happy that you are here to join us today for the third part of a series devoted to exploring telehealth and exploring the use of telehealth to address mental health needs for adolescents and young adults. Please mute your phone, or please mute your video, please. Okay, great, thank you. So again, also May is a busy month. It's also Mental Health Awareness Month. So it's very fitting that we are wrapping up the series during this national observance of the mental health awareness. And just a few notes on technology. This call is being recorded. So we like, if you are not speaking or if you're not voicing a comment or asking a question, to please go ahead and mute your phone and also your computer, so that way we can eliminate those technological distractions. There is a chat box that you are welcome to use to ask any questions or comments throughout the presentation. Also, if there's anything else that you would like to share in terms of resources. And again, we want to thank not just those of you that have been participating in our CoIIN for the past 2 years, but also other friends that have joined us to learn more today. And so we're going to start the session with a few reminders and announcements for our CoIIN participants in particular. And then we're going to go into the third series of our webinar program devoted to telehealth for addressing adolescent and young adult health mental needs, in partnership with the Center for Connected Health Policy and the National Consortium of Telehealth Resource Centers. And this particular session is going to focus on the integration of behavioral health in school-based telehealth programs. We know that schools are a key setting for addressing mental health needs for young people, and with schools kind of trying to transition back to some sort of normal operations, we definitely know that this is a key priority for many of you, especially as you are going to spend the next few months planning to see what's ahead in the fall. And then we'll wrap up with a few other reminders and announcements. And again, just a quick reminder that, this has been our global aim for the duration of our learning collaborative, which is focused on getting 80% screening rate for the young people ages 12 to 25 for a major depressive episode, again, using an age-appropriate standardized tool with documentation of a follow-up plan if the screen is positive. So this has kind of been the global goal that has really outlined our work, whether you are working on your public health teams or you're working in your clinical practices. So this is definitely something that we have been working towards collectively for the past 2 years and will continue to work on after the Learning Collaborative has ended. And with that, I will go ahead and turn it over to my colleague Anna for a few reminders and announcements.
Thank you, Eliana, and hello, good morning, everybody. As Eliana mentioned, my name is Anna, and I'm here with just a couple of reminders for those of you that are participating in the CoIIN. Those reminders here are that we are still using LifeQI, so please pop in there if you are ever looking for any of our archived learning sessions. If you're looking for any of our foundational documents to the CoIIN, you can find those in the folder in LifeQI, and there's still time to request TA funds if that's something that you'd like to do to wrap up your time with the project. And the form that you would need to fill out for that request is also located on LifeQI. Just a couple of points about some upcoming reporting that's due. Your state capacity assessments, your final 24-month assessment will be due on July 15th, and I will reach out to CoIIN team leads in mid-June, as I normally do, with some instructions on how to get that final assessment filled out. And then we are still requesting that every month you update your PDSA cycles within LifeQI. And again, add what you can and feel free to modify as plans change. And then my last little announcement before we turn it over to our guest speakers is for our CoIIN participants to stay tuned, that we are going to share some details for a project wrap-up webinar, and that is coming soon. We're thinking sometime in June for that. So stay tuned as we finalize those details so that we can all get together and celebrate the work that you've done over the past 2 years. And now, without further ado, as Eliana mentioned, this is our third and final learning session in our telehealth virtual learning series. And I am very excited to announce Lloyd Sermons, who is director of the Southeastern Telehealth Resource Center, who is going to kick off this session, and then he will pass it off to Sherrie Williams, who is the Chief of Operations at the Georgia-based nonprofit Global Partnership for Telehealth. And I will let Sherrie introduce herself a little bit more in depth as I hand it over to them. So without further ado, I will pass it over to Lloyd to share his screen with you all.
Great, and thank you. Let me get right here just to my presentation, and you should be seeing that now. Anna, is that you seeing the slide?
I do.
I know you guys have probably seen this map, and so I'm not going to spend a lot of time. As a matter of fact, I won't spend a lot of time talking, period. So I'm going to save as much time for Sherrie. Sherrie, when it comes to the school-based telemedicine portion, is definitely the expert there. And so, but I just want to make sure that you guys are all reminded. Once again, I know you've heard a couple of our colleagues from the telehealth resource centers, but just as a reminder, you know, we're here to provide technical assistance around telemedicine programs. And if you have not had the opportunity to get to know your telehealth resource center, then I just want to make sure that I kind of put that out there. I know some of you are probably in my region. Many of you may not be in my region, but I'm the director of the Southeastern Telehealth Resource Center, and I cover, as you see here on this map, the states of Alabama, Florida, Georgia, and South Carolina. That's my particular region. So if you're in my region, I would love the opportunity to get to know you a little more, and just, you know, of course, as a resource center, we're here to help any way we possibly can. What do we do as telehealth resource centers? We're federally funded. There's 14 total telehealth resource centers around the country that are funded by HRSA, which is the Health Resources Service Administration. But we can help out. You know, we track things like policy, reimbursement for a particular states, business models around telemedicine. You know, we assist people with equipment selection. As a matter of fact, this morning, you know, I've been working with someone on some equipment, trying to identify some equipment that might be best suited for their telemedicine program. Practice guidelines, program development, you know, so much more. And two, just the main thing is the resources. As the National Consortium of Telehealth Resource Centers, we have very, very valuable resources that are available to you guys for free. And just putting some resources here, telehealthresourcecenter.org, that's the main website for all the telehealth resource centers around the country. CCHP, I would encourage you, they're the national organization. Anna mentioned them a little bit earlier. If you're not on their mailing list, I would encourage you to go to their website and subscribe to their newsletter. May does a really good job. Her and her team do a wonderful job of keeping their finger on the pulse of what's going on, really from a national perspective. But then also, you know, they do every couple of years, they'll do a 50-state Medicaid report, and they just put out a lot of great information, especially as things are consistently changing around Medicare and CMS in regards to reimbursement. And then I put my resource, my website here as well, setrc.us. We have great resources there as well. Try to keep that as updated as I possibly can, so that people can just go there, find the resources that they need, you know, and then download those resources. And so with that, I will stop sharing my screen here, and I will turn it over to Sherrie. Sherrie Williams, she'll tell you a little more about her, but when it comes down to school-based telemedicine, Global Partnership for Telehealth, I do believe and feel very confident saying that they have one of the strongest school-based telemedicine programs in the country. And, you know, hopefully we'll be able to answer any questions that you have by the time this webinar series is over with today. So Sherrie, I'll turn it over to you.
Thank you, Lloyd. Hi, everyone. How are you? It's a pleasure to be with y'all today. I kind of laughed a little bit when you were talking about the cicadas. I am not having a cicada issue today, but I am working from home and I live near an Air Force base. So I will warn you, the A-10s are flying very, very low this morning, and it sometimes shakes my house when they fly by. And I am in the country, so there are lots of tractors going by. So if you hear anything, it is just a crazy little day in my neck of the woods this morning. So I apologize for any background noise. Thank you for letting me come today and talk about one of my favorite topics, which is school-based health. We'll kind of lay the groundwork this morning and then talk a little more about the integration of behavioral health services into school-based telehealth programs.
Sherrie, before you get going too much, we're not seeing the presentation slide, we're seeing your working slides. So if you'll
just fix that, let's try this again.
There you go, that's it.
Now you're seeing it? Okay, all right, perfect. I have a couple screens here and I never know which screen you guys can actually see, so thank you for that. So we'll get started. That is a lot of gobbledygook about me. The two things you need to understand about me is I am a social worker. I've been a social worker for about 23 years now. And I was calculating this morning, for almost half of my social work career, I've been working in school-based telehealth. I had not realized I had been doing that for half of my career until I was really thinking through that this morning. So I started off in a hospital setting with child and adolescent outpatient mental health programming, moved over to our little public schools here in my little very, very rural southern Georgia community, and acted as a guidance counselor for a couple of years. Telehealth came into our lives, and then I ran Georgia's very first school-based telehealth program, did that for a couple of years, and then moved over to the Global Partnership for Telehealth. If you see on your screen here, our company has been working in school-based health for a long time. Down in the kind of bottom center southern part of Georgia, there's a aqueduct. That is where I am currently located today, and that's where we set up our very first school-based telehealth program. And from that one school, you can kind of see how we've grown and multiplied and gotten bigger and bigger. 40 different school districts across several different states. And right at 150 schools, I actually think when we counted them today, it was closer to 160 schools that we are working with. So we've taken that one little model that we created here in Georgia and just multiplied it. It's a model that works very, very well. I will, tell you that if you've seen one school-based telehealth program, you've seen one school-based telehealth program. Even though the general model of implementing a school-based telehealth program is the same, there's certain best practices we follow. Every time you go into a school, obviously there are different needs that the community has, that the students have, and that school has. So we try to work with schools to understand what those needs are, and then from the best practices, formulate a school-based health program that's going to work best with the needs of that community and district. So a couple of things, just some level set information here. There's a lot of kids in the United States that are in school, and about 10% of in school are medically underserved because of lack of insurance, or they're underinsured. And of those 10% of students, about 15% of those come to school with a pre-existing medical condition, whether it's a primary condition, whether it's a mental health condition, combination of both. And obviously all students, regardless of whether they're fully insured, underinsured, or not insured at all, have common things that need to be taken care of in terms of physical condition, mental health, and the physical safety of a school. And schools are the front line to taking care of those things. We know that health impacts education. As students miss more and more days of school, they become higher risk of dropping out of school. We know that students who are chronically absent in the early years are behind in grade level reading. And if you look at children in grades 8th through 12th grade, as they're chronically absent, they become 7 times more likely to drop out of school. And that's a very significant number. So just like health impacts education, education also impacts health. When we look at the statistics, we know that adults who drop out of high school and do not graduate are at higher risk of diabetes. They tend to be smokers. Their life expectancy is a little shorter. And then we look at how health and education as a combination impacts society. If you're not healthy, you're not going to be fully employed, or you may be underemployed. You may not be able to work at all due to health reasons. So as you kind of start layering these things together, you can see how education and healthcare really play a complementary role with each other. When we first started school-based telehealth, and this was about in the early 2009, when we really started putting the parts and pieces together in my little community. We went to our school board, and I was an employee of the school district at that point in time. I went to the school board, and our school board members couldn't quite wrap their minds around why in the world would a public school want to start providing health care. We'd already had school nurses back in the tobacco money. When was that? In the early mid 90s. The tobacco money came down. We were able to hire 2 school nurses. And in this little community, we have 4 schools. We have a primary school, elementary school, a middle school, and a high school. So we were able to hire 2 nurses, and those nurses kind of floated back and forth around those schools. And it was funny. One of my dear friends was one of the first school nurses. She wasn't afforded an office. So her trunk of her car became her office, and she would have these little Tupperware dishes of all kinds of, medical supplies, Band-Aids. And, as the children would bring their medicine to school that they would have to take at school, she would have little boxes with them. And so she really worked as a traveling nurse out of the trunk of her car for a couple of years. Well, even then, the school here started realizing that, well, maybe the school nurse, maybe she does play a significant role in helping these kids. They started looking at the absentee rate, and you could see as the children healthcare needs were being taken care of, they were in school a little more often. Parents were more likely, and this is kind of a double-edged sword here, they were more likely to send their children to school even on days when they didn't feel well, because they knew a school nurse was available. In our community, we're probably 30 to 40 miles away from the next larger town that may have a little more medical care. So in our community, which has a huge poverty rate, not a lot of people have transportation, it's a major ordeal to get from here to the physician and back home. So they were a little more inclined to send their children to school to see that nurse as that medical care provider. And, whether that's right, wrong, indifferent, how you want to look at it, it began to bridge a gap between our school and our families. And that bridge between the two was healthcare. So it was kind of interesting to see how that all evolved. And is school-based health a passing trend? I don't think so. What we have seen since we started in 2009, the number of school-based telehealth centers has grown significantly. If you just look at the numbers between 2007 and 2017, there was a huge increase of schools that were implementing school-based telehealth programs. We are, in the midst of COVID, hopefully toward the end of COVID, and we kind of see what happened since the pandemic and the public health emergency started last March. And that was, telehealth was already kind of trying to find its place in the healthcare world. The adoption, that people were becoming a little more aware of telehealth. You were beginning to see some mainstream television commercials that United Healthcare had, a couple of cute ones when they were talking about telehealth. So we started seeing telehealth being ingrained into just the public mindset, slowly. And then, boom, COVID happens, and then everybody's scrambling and wondering what to do. And telehealth was the answer. Now, depending on what magazine you read, what experts you're listening to, you're hearing different things. So I read an article just this week, and it was about one of our giant telehealth companies here in the US. And they saw huge utilization during the height of the pandemic. And then, everybody, not just them, everybody got, huge trends, and then it kind of leveled out and plateaued. We had the second wave of COVID. It went back up a little bit, not as high as the first time, and then it plateaued again. And the plateau was not as plateau earlier. So we know that there was a little more adoption, a little more staying power. And now you're just kind of slowly, as people are getting more comfortable with their lives again and going back to their doctor's offices or what have you, you're beginning to see the utilization in telehealth trend down again. Still not nearly as low as it was pre-pandemic, but it is trending down a little bit. So what do we think is going to happen? Do we think there's going to be a leveling off? Do we think that, telehealth is going to get back up again? Or do we see it just crashing out and going back to pre-pandemic utilization? I don't know. From where I'm sitting, we're still seeing people, inquiring with us about starting telehealth programs. Schools got a little iffy, obviously. Some of our schools in Georgia have not gone back yet. They're still doing virtual models. So school-based health in general kind of is in the balance, and what do you do with that? Are the students' healthcare needs currently being met while they're in a virtual environment? Each school district has kind of handled that differently. We've talked to some school nurses. Some have, started connecting with families virtually. Some, just aren't, and the healthcare needs of those students aren't necessarily being met the way they were when they were in school. So, there's a bunch of schools of thought on where telehealth is going. I hope it's around. I hope it sticks. I think it's a really good thing, and it really has benefited the schools that we've been working in. So this is one of the models, or this is the model we came up with when we started the first school-based telehealth program here in our community. And we learned a couple of things, and you'll hear me talk about the local community a lot today. There are, different flavors of telehealth, just like there are different flavors of ice cream. And some people like this and some people like that. One of the biggest things that we learned very, very early on in the implementation of our first program, we thought that it would be a real cool thing, that people would get excited about it if we started partnering with some of the very large hospitals in our state. We have a couple of very well-known health systems. We have some really awesome pediatric hospitals and providers all around our state, specifically up in the Atlanta area, which for me is 4 hours north. We thought that would be a really cool thing, would really attract people, and they would want to use our school-based health program. What we didn't count on, however, was the huge pushback that we would have from our local community, specifically our physicians. They saw telehealth as a patient stealer. They, were upset that we were interrupting continuity of care between the primary care provider and the patient. And you know what? They were right. We had not thought about that. And we're going to talk a little bit later on about stakeholders. So we're going to put a pin in that conversation and come back to that later. So we quickly had to regroup and rethink how we were doing things. So the student had always been in the center of everything that we had tried to do in our implementation. Rather than just that student to that remote specialist who may be 4 hours away in Atlanta, we started thinking differently. We started thinking about our local providers. And, at first glance, the thought was, we don't really have anything in our local community to offer. But you know what? We did. We had 2 primary care providers, one not necessarily a pediatrician, but did see most of the children in our community from a primary care standpoint. We had a little local community service board, which provided a small amount of mental and behavioral health in our community. And then we had a couple other little, dental and that sort of thing, and our little local hospital. So we regrouped, came back to the table, brought those people together, and then we developed this model. And it made so much more sense. Our community supported it. Parents got excited about it. And we didn't interrupt care. So keep this model in mind as we talk today. Like I said, if you've seen one school-based health program, you've seen one. This model may need to be shifted somewhat depending on the school district, the community, and the needs. But this is our basic business design when we go into schools. One of the big things that we always ask about, well, how do you get funded? Obviously, right now, there are lots of grants that are available due to COVID. A lot of schools have taken advantage of this all throughout the US. So, there's tons of grants available from a federal, state, sometimes even local grants are available. I know a lot of Rotary clubs and junior women leagues and such as that will sometimes pick something in the community to raise money for. A lot of schools have been successful in buying parts and pieces of their telehealth program through some of that local funding. Partnering with hospitals and local health systems has been a great place to find funding, foundations, and then sometimes school boards end up footing the bill themselves. So I want to go through 6 points for successful school-based telehealth. And I will say, I cannot see my chat in this view that I'm in now. So if there are any questions, please don't hesitate to unmute yourself and just say, hey, Sherrie, I have a question about that. I welcome the back and forth conversation. So don't hesitate at all to interrupt me. The number one thing when planning anything, obviously, is it can't be accidental. It's got to be very intentional, and you have to think through planning and exactly what you're trying to accomplish. So when you're thinking about intentional program development, there are several steps that you go through, starting with a needs analysis, defining your services, your program model, technology models that you may want to use. What's your business model? Here in our state, most of our insurance companies reimburse for a school-based telehealth visit. Some states, I think I don't know that all 50 states have adopted that reimbursement model yet, but that's a business model. That's a little bit of money that can come back into the schools, especially when you're billing the originating site code. Here in our state, I believe that reimbursement is, depending on which insurance company or Medicaid plan, I think it's anywhere from $25 to $32, I think, on the high side. So that's reimbursement for the school. That's money back into that school-based telehealth program. And then how are you going to implement your plan? What is your performance monitoring plan? Data is very important. We'll talk about that a little more later. Getting the program up and going, and then monitoring and constant improvement there. The second point of the 6, fully implement best practice guidelines. There are lots of resources out there. I just pulled these 4 together. These are 4 that we pull from on a general basis. Obviously, our Global Partnership for Telehealth, we are here for any help that you may need. The Rural Health Information Hub has wonderful toolkits that are available. It's free. Please take a look at that. A lot of them are specific to schools. If you're doing behavioral health, if you're doing rural health, depending on your setting, you can find a lot of tools there. Lloyd talked about the National Consortium of Telehealth Resource Centers. I cannot recommend that place enough. And there's a lot of resource centers. Go to all their pages, take a look at all of them. You're going to glean information, that may be different from one resource center to another, just depending on the region that they're covering. So make sure you're checking out that. And then the American Telemedicine Association, some of their stuff is not free. You have to join, but occasionally they do have some free things available there, and it's good information. So really start thinking about where you're going to take your best practices from. How are you going to get this information? And really start formulating those best practices and put it into your model that's going to work in your district and your schools.
Hey, Sherrie?
Yes.
This is Liliana from AmChip. We do have a question in the chat related to models. Are there models that partner with out-of-state providers? And I think that this is important because we've talked about access, but also just having providers, even a resource of providers available, it can be very limiting depending on where youth are located or where they reside.
Absolutely. And I'm not sure which state you are from that's asking the question. Take a look at your state rules and regulations. During COVID, most states really loosened their requirements for out-of-state providers. In Georgia, and I'll pick on us, we had a really weird rule, and I'm not sure if it was intentional or if it was accidental. But in our Medicaid guidelines for Georgia, it said that if you were a provider who was going to be practicing via telehealth in the state of Georgia, you had to have a physical location in Georgia also. That kind of, takes away the beauty of telehealth when you're required to have a physical location. And some of that was being talked about and worked through in our state when COVID hit, and kind of COVID took care of that problem in and of itself, and we haven't had to go back to that. Florida has been somewhat of a leader in this area. They began offering several years ago a telehealth only license for providers outside of the state. When we're talking about mental health, such as we are today, we know that there's a huge shortage of mental health providers. Here in Georgia, it's a major issue for our rural communities to get enough behavioral health specialists to come in. Back before telehealth was, part of our lives, trying to attract a psychiatrist or a psychologist or anybody into a rural community like mine, forget it. They're not going to leave the cities to come to, Nowhereville, where tractors are driving by and interrupting your day. It was just very difficult. It is also somewhat difficult when your state puts a lot of rules and regulations around out-of-state providers, because sometimes states just don't have the resources. So if we can start leveraging each other all across the U.S., I think we're going to set up a much better situation for, specifically to our students in that matter. But I do, to answer your question, to make this long story short, look at the rules and regulations for your state, find out what their requirements are for out-of-state providers, and go from there. That will guide you on your way.
Yeah, and one of the things too there that's important, Sherrie, too, is, also what licensure board, manages those providers. So if it's MDs, then of course, what does your composite board, your medical board say about those out-of-state providers? If it's a psychologist, or if it's, if it's nurse practitioners, or, so there's some different levels that you have to look at to different licensure boards, I guess you could say. But I will say this, the majority, probably all of your states, are going to require some sort of licensure in the particular state where the patient is located at the time of service. And that's what you have to look at.
Thank you, Lloyd. So point number 3, involve that local medical community. I told you to put a pin in that earlier. So let's talk a little more about keeping care local. And I keep using my community as a point of reference, because it's a good example of what happens, specifically if you're talking about rural communities. The first thing we do when we go in and start talking to a school, we're like, well, let's do a local scavenger hunt. Let's make a list of everything that's happening in your community, from, it may be Department of Family and Children's Services, it may be dental offices, it may be, maybe a mental health provider from, a couple counties over, but they're coming in a couple of days a week to see folks in the community, or they may be doing home support therapies, primary care, just the whole list. Do a real thorough scan of your community and find out what's already happening there. We have a very tiny hospital. It's a 12-bed hospital. It's tiny. They don't offer a whole lot there. But let's think about the economic impact. So, I was using Atlanta as an example. Prior to telehealth being here, a lot of our families were going outside of our community. Many of them who had to see specialists were having to drive as far away as Atlanta, which is, a 4-hour one-way trip. And once you're making the effort to go out of the community, you've got transportation, you've gotten to where you need to be, that provider may order lab work, may order imaging, may order a whole list of things. You're probably going to get those things done while you're wherever you are, if it's in Atlanta or your next neighboring town or whatever, and you've bypassed your local hospital or your local lab or your local provider's office. So the money is leaving the community and it's not coming back to support what's already there. So I will always say telehealth should be there as a support and an enhancement to what's happening in the community. It should never undermine what's there. We have to think about it from economic impact. We have to think about it from continuity of care and what's accessible to your family. So the more we can shop local, the more we can keep local, the better. And then obviously we're not going to get, hematology or, whatever kind of random specialist probably is not going to come to my local community to set up shop. So I think then it's okay to start looking outside because those dollars were going to go outside the community anyway. And so those are okay. So really think shopping local, staying local, and keeping as much care in that local community as possible. So let's talk about bringing stakeholders to the table. And we can think of stakeholders in two different groups. One, we have our school stakeholders, and then we have our community stakeholders. From the school aspect, obviously, administrators, school board, those who are having direct contact with students on a daily basis. IT support is huge. So many times, whether it's in a school setting or a hospital setting or a clinic setting, wherever it is we're working, sometimes that IT piece, for whatever reason, just gets completely left out. And then once, whoever, decides they're going to implement this program, we go in to start working. And, the first thing the IT people say, well, who are y'all and what are you doing? And no, we didn't open up these firewalls. And no, you can't have access to these ports. And then you're kind of backtracking. It's kind of 2 steps forward and 10 steps backwards to get it going. So don't leave out the IT person. They're really, really important. And then from the community, think about who needs to be there. Obviously, you probably want family representation. You want any mental health providers that may be local or maybe, just outside of that local community. And then the primary care providers, the health systems. Bring everybody to the table and let's really talk about where the gaps in services are and where our school-based health program can start plugging in and making sense. And then focus on the student. Obviously, everything we do in a school-based telehealth program, that students should be at the very center of everything, whether it's their school performance and academics. And I will tell you, there's been some studies that have loosely said that school-based telehealth impacts academics. It's really hard to draw a direct line between the two, but there's kind of a squiggly line and it does come together. So there is a indirect correlation, I guess you can say, between school-based telehealth and school performance. If the child's not at school, they're not going to learn, they're not going to perform well. So you can kind of start making those conclusions. High school completion, we're keeping those students there. We're reducing absenteeism. We are able to take care of any mental health needs that may be not being taken care of outside of the school. We can create a safer school environment, and we can provide a normal growing up experience as possible if we're able to take care of all these different facets of a child's life. And then lastly, collect data. I am not a data collector. I absolutely hate it. I love looking at data. I love it when somebody else collects the data and shows it to me, but I hate collecting it. But it is so crucial to the success of your program, specifically if you're going after funding. If you're getting HRSA grants or any other federal grants, there's required data collection there, and it's there for a reason. It is painful to try to collect it and try to make it make some sense, but it is so important. It helps you gauge the success of your program. It helps you figure out what direction to start moving in, and it can help you go after more funding in the future if you can prove that what you're doing is providing positive impact. So when you're thinking about where are you going to collect this data, you can think about it in a couple of different buckets. You can look at, general school data, absenteeism. Can we, pull the students who are missing 15 days or more, take a look at that subset of students and determine as they enrolled and started taking advantage of telehealth offerings, whether it be, physical health care, behavioral health care, whatever it is, do we see a decline in how many days they're missing? That's a great indication that people are taking advantage of your school-based telehealth program that need to, and that you're doing good work. Then take a look at utilization reports. What type of visits are you seeing? What's the payer type? Is your whole school automatically enrolled in your program, or is it an individual enrollment? So take a look at your enrollment numbers there, and then your cost, expenditures, and your savings. If you're in a situation where your state does allow the school to be reimbursed, are you taking advantage of that? And, what's your budget looking like? Are you doing surveys with your parents? Are you determining, mileage saved? Is it easier for them to get care at school, or are they having to drive 50 or 100 miles round trip to get that same type of care? So just kind of think through your data points. These are just some examples of things that you can start looking at. One interesting thing under school data where it says substitute teacher usage, one of the things that we found in the early days when we started doing this was that our teachers have health issues, a lot of them. And it was kind of funny, the number one thing that we saw were UTIs. Teachers are in the classroom all day long and they don't have an opportunity to take a restroom break. So we saw a lot of UTIs. And when the teachers were getting UTIs or high blood pressure was another big issue, they were having to leave school. In our situation, they would be gone for a half a day or a whole day to take care of that appointment, do whatever they needed to do, drive back home. And by the time they got back home, usually, it was too late to come to work anyway. So our school board was hiring a lot of substitute teachers. Once we had telehealth involved in our school, we opened it up to our faculty and staff. And there for a while, it was probably a 50-50 split on the number of students and the number of teachers and faculty who were using the services. So we found great value in allowing our faculty and staff to use that. And that was a good indication. We were able to look at, we're keeping teachers in the classroom a little more often. We're hiring fewer substitute teachers. That was real dollars and cents that we were able to report back to our school board that kind of helped them. The light bulb started going off and they sort of understood it at that point. So when we start, integrating behavioral health in.
Sherrie, real quick, question in the chat box. How have you overcome barriers such as lack of internet access, lack of computers or tablets for students, to participate?
So if we can just put a pin in that question, I do have a slide that's going to address it. And it is a significant barrier. And I will say, over the past year, 2, 3 or so, it's gotten a little bit better. But if I can just hold that question just for a second, I will answer that in just a minute. So we do know that about 1 in 5 children between ages of 13 and 18 are dealing with some type of mental health, behavioral health condition. And we're expecting them to come to school, and we're expecting them to learn, and we're expecting them to behave and feel good and have a smile on their face. That's just not fair. So what can we as school districts begin doing to help those students who are struggling and are having some problems? Teen suicide has gone so high. It's a 76% increase between 2007 and 2017. And I'm sure if we look at, especially during the pandemic, when children were isolated and aren't going to school, there are some students at this point are only communicating via social media, and we know how damaging that can be to fragile egos and to developing brains. I know just in my area, there have been a significant number of suicides over the past 2 years with students aged 13 to about 21 or so. And if you looked at the data in your community and in your state, you're probably not far off from what I'm experiencing here. So we know that there are issues that are happening with our students, and we need to pay special attention there. So we look at a multi-tiered support system, and school systems may address this a little differently. This is just a very common pyramid of the continuum of school-based mental health services. Where do we start screening our students? And I think that's going to be maybe a little different depending on your district, on what's allowable, what our administrators are comfortable with, our parents are comfortable with. But down in that very bottom section there, where it's a school-based prevention and universal interventions, are there any universal screenings that we're using? And I think out loud about these kind of things. It's not uncommon for our health departments, our state health departments, to come inside the school and give flu shots or, whatever they're doing. Is there a place there where maybe our mental health providers come in and they do screenings with everyone? I know in our state here in Georgia, and it probably happens in your state, we do a physical school safety survey every single year to find out, are our students, do they feel comfortable coming to school? Are there any unmet needs? Is bullying a problem? What's the issue there? Could we take that same thing and start thinking about the mental health of our students and do that from a universal standpoint? So we have a little early intervention. We can start looking at students who may be struggling a little more than others. And then how do we start building that in? And where does telehealth come into here? Are we going to use telehealth to do the universal screenings, which probably that makes no sense, but are we going to do there? Are we going to hold telehealth back until we have the students with severe and chronic problems? Or where in that continuing are we going to, insert a school-based telehealth so that we can really start enveloping these students and taking care of their needs? And the big question to use telehealth or not to use telehealth, What side of that slide are you on? Are you in a community that has few providers? Are you in an area where students, for whatever reason, can't access care? Is there just not enough support for the providers that are in that community? They need backup. And is follow-up care difficult for your families? If you're thinking, yeah, I probably don't need telehealth in my community, that probably means you're in a situation where you have a lot of mental health providers in your community. Maybe the mental health providers are coming on campus, every day, and they're seeing students on a regular basis. So students have easy access to the care, and follow-up is easy and consistent. Telehealth may not be right for your school district, but it very well may begin to fill in some of those gaps that are being left open. When we're talking about setting up a school-based mental health program, think of it in three things. Involve your key stakeholders that we talked about. Location matters. If you put a sign on the outside of the door as students walk down the hall that says mental health room or behavioral health room or whatever, they're not going to go in there. We've had schools that started labeling things like this because it's kind of cool. They're very proud of their program they situated, but their utilization was nothing because no high school student is going to walk in and everyone see them and make fun of them. It just kind of compounds the issue. So really think about the location of your school-based mental health program, and then communication and team approach. You really have to let people know that these services are available. Telehealth in general, regardless of the environment, is not a build it and they will come situation. You really have to let people know that it's there and how to access it. So now I want to start talking about that question that was just asked in the chat box about equipment and broadband and connectivity and how are you going to start implementing this program? So I'm going to talk about it in two different ways. One is if you're doing telemental health or telebehavioral health only, you're not interested in primary care, you're not interested in, hematology or any of that other specialty care, you only want to take care of the mental and behavioral health issues. Use what you have, BYOD. We see lots of school districts, they don't have huge budgets for, fancy telehealth equipment. They're going to use what they have. They may have a couple of laptop computers. They may have, some Chromebooks, whatever it may be that's available. They usually set up their programs inside the existing school nurse's office or inside the existing school guidance counselor's office. And students just kind of come and go. So when you're looking at that from an equipment standpoint, it's zero. You've already got it. You've already paid for it, for whatever other reason, and you just had some extras sitting around that you can use there. So from an equipment standpoint, getting this going could be zero. Most secure services run $50 to $100 a month. There are some free programs out on the market. Be careful. Some things are genuinely free. Most things are not. You have access to a couple of buttons inside your program, but if you click on this one the next time, they're going to start billing you $25 a month. And then, you click on this button, it's another $25. So there's some hidden costs out there. Be really careful with what you choose. Choose carefully and do your homework. And then from a full service telehealth program, you're looking at, could be around $10,000, $12,000 if you're going to do a full-blown, fancy school-based telehealth program. That includes exam scopes, so you can look in the ears and the back of the throat. It includes digital stethoscopes so that you are able to pass heart and lung sounds in a live session. And again, you can probably use that same telehealth service that runs $50 to $100 a month. Again, watch out for hidden costs. When we're talking about broadband, it gets very tricky. And like I said, I've seen over the past several years, it's gotten a little better, for whatever reason. A lot of school districts have taken advantage of, E-rate. They're in the CARES funding that came about. There was a huge emphasis on broadband. In our state, we're seeing our local electric membership corporations partner with internet service providers to start offering broadband in communities that couldn't get it. And I always say access to internet, your zip code determines how well you get connectivity. It's no longer about the haves and the have-nots. It's literally about what is your address, and is your street address on a line where fiber has been run or where broadband is available. If not, it doesn't matter how much money you have, you're not going to get broadband unless you're going to pay somebody to bring a line to you. So broadband has been a little bit of the great equalizer in terms of what you can and can't do. There is currently FCC just opened up funding that is directed toward our consumers. That's a really cool thing to see happening there. I think there's $3.2 billion that's been federally designated to consumers. If you go to the FCC website, it's the emergency broadband, Lloyd, what is it? The EBB, emergency broadband benefit.
Emergency broadband benefit.
So if you Google emergency broadband benefit, it will walk families through eligibility and how to apply. So there's certain things you have to be eligible for. And it's if you are on tribal lands, I believe you get $75 off of your internet bill. If you're not on tribal lands, I think it's a $50 waiver every month. I believe it's $100 towards a laptop. And there's a couple other things that are there. That's really cool. I really, if you've not taken advantage of this, go look at the EBB. Get the information out in your community. Now, $3.2 billion kind of sounds like a lot. You know, when I'm balancing my checkbook, that sounds like a lot of money. But when you're talking about opening it up to all 50 states and for everybody who is eligible, I don't really know how long this $3.2 billion will last. I've talked to a couple.
Local providers have to be participating in the program as well. So.
Exactly. That's what I was going to say. So I've talked to several of the ISPs throughout our state. Some of them have elected not to participate. There's a lot of work on the provider standpoint, and some of them just felt it was more work than it was financially worth for them. And they were going to end up being upside down. So they elected not to do it. We have others that were like, yes, this is so good for our community. We have so many people in our community that need this help. We're going to do whatever it takes to get these people connected. So see what's available. The FCC has a wonderful running list divided up by state of who is participating in that state. And then get the information out to your consumers. You know, if we're at the end of school, but if there's a way that your schools can send notices home to families, hey, did you know this is available? You may qualify. Go to this website, you know, work through this. And then, you know, you kind of laugh, ha ha. Well, if they're not able to get broadband, how are they going to go to a website? That is a trick. It is tricky. You know, I don't know if your libraries have access or if there are some local community spots to get families in to start helping them work through the FCC eligibility process, but it's wonderful. So check and see what's there. Obviously, if they don't have fiber or broadband available at their address, that's tricky. And I think over the next coming years, we're going to start seeing that divide getting more narrow and more narrow. You know, and if you're reading the news, you know, Elon Musk is shooting up satellites, you know, on just hundreds at a time. Is that going to be our saving grace for the broadband answer? I don't know. But there are a lot of people taking a look at that. There are a lot of interesting things happening. I think the FCC funding is one of the most interesting things that's come about lately. So take a look at those things.
Sherrie?
Yes.
I just want to give you a quick time check. We have about 6 minutes left in our session.
Okay, perfect. I am toward the end. Engaging families and students, like I said, school-based telehealth in general is not a build it and they will come. As much as we have become familiar with telehealth over the past year or so, there may be some hesitancy there as well. Teach people how to access your program, teach families how to access it, teach students how to access it, and make sure everyone knows that it's available. You know, if you have a telehealth cart, put it out in the hallway and let people come by and take a look at it and feel more comfortable with it. And with that is my last slide. And I am open to any questions or discussion that you may have. If you have questions that you're not comfortable asking out loud, here's my contact information. Don't hesitate to shoot me over an email, and I'm happy to help.
Thanks so much, Sherrie. I'd like to invite our participants to ask any questions that you might have of Sherrie while she's here live. Feel free to unmute yourself or to type that into the chat box. And I can share a comment that came in towards the beginning of your presentation, Sherrie. And the comment is, my concern with this method is not being able to do wellness exams, which is one of the main ways we find health problems in these students. So can you talk a little bit about how that fits into the model that you described?
Sure. And telehealth is not is not appropriate for everything. Obviously, it's very difficult to palpate an abdomen and and know what's going on. You're having to ask the school nurse or whoever that healthcare provider is there with the student to palpate, and then give you back information. You can't give somebody a shot through. So there's limitations there. What we've seen in a lot of situations. We have a community that we're working in now, and they have co-located. They've put a doctor's office inside the middle school. So the middle school has become the health hub. There's a nurse practitioner and maybe 2 nurse practitioners and several nurses in the hub. And what they do, they pick wellness days and they go from school to school to school, and they do the wellness visits there. We've got a couple of other locations that we work with that haven't co-located on site, but the doctor set up a couple of days a month, and they send a nurse practitioner over to the school for those types of things. So you kind of have to get creative. Obviously, you're not going to do 100% of your well check through telehealth. You can do some of it, but you obviously can't do it all. So you really have to think about the partnerships in your community and how you can make that work if well visits is something that you intend to do as part of your program.
I know one of the big things, Sherrie, that we see a lot of with families and with children is like medication management and, doing those type of visits as well, and handling and managing those type of visits. So we're, maybe as a parent, instead of having to go check my child out of school and take them, for their follow-up appointment so that we can get the refill. A lot of that now in our school-based programs, a lot of that's done via the telemedicine, and and so I think that's kind of an important aspect too. We see a lot of that with the school-based programs.
And when we're talking about medication refills, there is a little problem that most everybody has had over the many years, and it's the Ryan-Haight Act. This act basically makes it, depending on who your legal counsel is, makes it impossible for students to get their ADHD medications refilled, any of those controlled substances refilled through telehealth, unless they've seen that doctor at least once or every so often. And it really depends on who your legal counsel is and how they're interpreting the rule. That rule was in the process of being updated as COVID hit. When COVID happened, there was a lot of waivers that happened. So really pay attention to the federal rules and regulations around medication management and what kind of medications can be handled through telehealth versus what are those types of medications that the student's still going to have to go in, or the provider's going to have to come on site to see that patient in person.
And probably the last question, Sherrie, how have you seen clinics cost covered for uninsured students, or those students in the school system maybe that's not covered?
So, and as I mentioned earlier, it's not a cookie cutter approach. It depends on that community and the appetite of that school district. What we have seen from a very successful standpoint are memorandums of agreements between the school district and the providers. So the providers would volunteer, X% of their telehealth encounters would be at no cost to that student if the student couldn't pay for it. So they were willing to write off a lot of those appointments. So that's we've seen being very successful. Sometimes the school has funding that they're able to help with to offset some of those costs. Probably the most common model is working with those local providers to work out a situation where if a student doesn't have insurance and they do not have the financial means, that those things are written off, or there's a very generous sliding scale that happens there. I believe that healthcare should be available to anyone who needs it. So my feeling is that if a school different district is experiencing students who are not able to access care because of no insurance or lack of financial resources, there are creative ways to handle that and partnering with your local providers. And that's another reason to shop local. Your local providers are probably much more willing to help take care of those students than providers who don't have a vested interest in your community.
Well, thank you so much. We are at the top of the hour now, Sherrie and Lloyd. Really appreciate you both coming on today to speak with our group here. And thank you to our audience for participating and listening to the talk today. I am going to quickly put up contact information for Eliana and myself. If you have any questions generally about the CoIIN, please reach out. And in our follow-up email to this session, I will share Sherrie's contact information again in case anybody has any follow-up questions. So with that, our session is over for today, and we will talk to you all soon.
Thank you.
Bye-bye, everyone.